Good morning. My name is Sonia Kurunathan. I am a physical therapist here at Eisenhower. I've been working here for 7 years. I have been a physical therapist for 7 years, and I have pelvic health therapy experience for 7 years. So what we're going to talk to you today is about physical therapy approach to incontinence and pelvic organ prolapse. Now, the first thing that we talk about, and the main reason most of you came here today, is to talk about incontinence. So that can be urinary or fecal incontinence. Sometimes it can be an involuntary loss of gas or flatulence. The other thing that we talk about is urgency or frequency. So sometimes patients will have difficulty making it to the bathroom in time, or they'll make it to the bathroom in time because they have that sense of strong urgency. And that could mean that you have triggers that are like the keys in the doorknob. It could mean that you hear the water running. It could also mean that you're parking your car into your driveway or your garage and you're hearing the garage door close, and that gives you that sense of urgency that you need to rush to the bathroom. So frequency is also something that we might address with you. What that means is that if you're going to the bathroom more frequent than every 3 to 4 hours, then that means that you have what we call urinary or bowel frequency. So that might mean that we go through talking to you about how to schedule and break down and expand on how much you delay going to the bathroom. Nocturia is kind of a funny word. It means going to the bathroom or urinating at night. So if you're younger than 60, if you're going to the bathroom at all, waking up in the middle of the night, other than the fact that you're a light sleeper, it could mean that you have nocturia. If you are over 60 and you are waking up once, that's normal. But if you're waking up more than once, we'll talk to you about how to improve getting better sleep and reducing the amount of times that you're going to the bathroom at night. Constipation is a big one. We treat patients with constipation. We might talk to you about your water, your fiber intake. We also might talk to you about tightnesses in your body or weaknesses, or not being able to relax your pelvic floor muscles when you need to avoid on the toilet. But constipation can really play a big part on your incontinence or your prolapse. And so we'll get into more of that. Sexual intercourse pain is something that we often treat, but it is also something that we treat in pelvic pain as well. So we might treat a patient that has pain when they sit in that region of the pelvis. They might have pain when they're moving their back. They might also have pain with just having a pelvic exam, and it has nothing to do with sexual intercourse. Erectile dysfunction is something that we treat by addressing the tightnesses and the weaknesses in your pelvic floor muscles, and then also giving you education on activity modification. Post-cancer. Now I've written post-cancer, but it also means that we can address something that's going on while you have cancer. It could mean that you just had your uterus removed because you have uterine cancer. It can mean that you have your ovaries removed because you have ovarian cancer. It can also mean that you've had radiation, or you're having chemotherapy and you're having some incontinence. Regardless of what cancer-related treatment you're having or undergoing, it's something that we can address with physical therapy. Now, pregnancy and postpartum is a big topic because now we've had the birthing center. So if you know someone that is pregnant or is in the postpartum stage of their life, we can help them reduce their pain in their pelvis when they're moving. And if they have incontinence, we can help improve their pelvic floor muscle strength. Or we can teach them tactics so that they can reduce the amount of leakage they have because of the amount of pressure they're having in their pelvis. And postpartum, if you are already at that stage where the doctor's cleared you at your 6-week appointment, and you're having leakage or you're having pain with sexual intercourse, then we can help you treat that and help navigate you through having less pain or improve your function. So what is incontinence? Incontinence is a loss of urine or feces. Sometimes incontinence to patients might mean that you're passing gas when you're walking. But all of those things kind of play a part on something that might be embarrassing to you and something that we can treat. So we tell patients when they come in that incontinence is common, and you're gonna find that as you mature in age that it might be more common for you and your friends, but it's not necessarily normal. And so these are some of the incontinences that we have. These are mostly for urinary incontinence, but it's stress, urgency, mixed, and overflow. But the main things that we're going to talk about today are stress and urgency. So you're like, well, these are weird words. I know that I have incontinence, but what's the difference? So stress incontinence is when you might have coughing, sneezing, laughing, jumping, running, or any kind of movement. So that might mean like you lift your groceries out of your trunk and then you have leakage. Those are things that we can address and help you navigate how to improve that. Urgency incontinence. So a lot of patients come in here and they say, yeah, when I stick my key in the doorknob, I have that sense that I need to rush to the bathroom, and I have leakage on the way if I don't get that key in the doorknob real quick. Other patients might say, like we talked about before, they might pass a restroom in the Target or the grocery store, and they automatically know where the restrooms are because if they don't go, they're gonna have leakage. They also might be patients that are driving into the driveway or the garage, and as soon as that garage door closes, you have that sense of urgency to go to the bathroom. Sometimes tightness can be an issue, but sometimes weakness can be an issue. And then mixed incontinence is a combination of them both. So you might have coughing, sneezing, laughing, and you might have that sense of urgency. And so we'll get into a little bit more of what that means. What is pelvic organ prolapse? So a lot of patients or a lot of people today came in and they wanted to know what incontinence was, and they may not have any clue what pelvic organ prolapse is. But pelvic organ prolapse is, there are multiple organs that your pelvis supports. So if this is our pelvis, this is supporting, there's three main organs that it's supporting. It's supporting your bladder, it's supporting your uterus, and it's supporting your rectum. And then within those pelvic organ prolapses, you could have intestines that are coming from the rectum, or you can have the urethra that's coming from the bladder. Now, if you look at the top of the first picture here, you can see that there is a normal anatomy. That normal anatomy means that everything is put in its right spot. So you see the bladder, you see the uterus, you see the rectum, and then below that are pelvic floor muscles that should be right below that. The pelvic floor muscles, what they do is they help support the organs. What they also do is they help with sphincteric control. So what that basically means is that it helps you control whether or not you need to void on the toilet or if you need to hold it because you haven't quite made it to the toilet. So when we have a pelvic organ prolapse, you'll notice that there's a drop in the normal position. So right next to the normal anatomy, you see a picture that says cystocele. That means the bladder has dropped from a normal position down into the vagina. So in this particular pelvis is a female because we know that there's a bladder and then there's a uterus right on top. So if you look at the second picture, there is a uterine prolapse, and that prolapse is going a little deeper into the vagina. Then we see the rectocele. The rectocele is pushing into the vagina too. Oftentimes, if you are a male that's watching, or if you know of a male that has a prolapse, they will have a rectocele because they don't have a uterus, and often they don't have a bladder prolapse because there's nowhere to go. But it's common to have maybe sometimes a small intestines, which is an enterocele, or a rectocele, which is the rectum coming out. It's a little bit more rare to see the enterocoel or the urethrocoel, which are the small intestines in the urethra, but it's very, very common to see the first three, which is the bladder, the uterus, and the rectum. So patients might say, well, how do I know if I have a prolapse? Oftentimes patients will say, well, I have this sense of feeling like it's heavy, or when I stand up, I feel like this heaviness in my pelvis. Sometimes patients can see that they have a pelvic organ prolapse, and they might say, oh yeah, I felt something that wasn't normal there. And so that's a good time to talk to your doctor about whether or not you need to be screened for the pelvic organ prolapse. Now, there are different grading for the pelvic organ prolapse. You can see in the picture here, I have a uterus, and the normal position is at the top, and then the second picture is the first degree. What that basically means is that from the vagina to the uterus, there is a depth of the vagina, and then the cervix is right here. If you were to drop just to my index finger here, that would be more like a first degree pelvic organ prolapse. So how we might test that in the clinic is we might insert our finger in the patient's vagina, and then we might ask you to bear down or cough. If you drop down here and I can feel that, then that tells me that's a first degree. If you drop down here, that tells me that it's a second degree. If you drop down here, or it's coming out of the vagina just a little bit, then that tells us that's a third degree. Now, if your organ happens to come out completely out of the vagina, then that's more of a fourth degree. Now, I haven't listed it. You don't see that on the screens here, and that's intentional because for physical therapy to work, you have to be in one of these three realms. You have to be a first degree, second degree, third degree. Now, it's not uncommon that a patient might have first degree and then have a second degree uterine and a third degree rectocoel. So you might have a version of all three, or it's not uncommon for a patient to have a first degree bladder prolapse and then a second degree uterine prolapse and then a first degree rectocoel. All of those things can be treated, but once you get into the fourth degree, when the organ's actually coming out, then that might be a surgical intervention, and that's something that you can talk to your gynecologist or your urogynecologist when you get a chance, if that's something that's of concern for you. Now, what we do with pelvic organ prolapse is we typically teach a patient how to do Kegels in order to bring back the position of the prolapse. We also will teach you various things that I want you to avoid. A big reason why a patient might have pelvic organ prolapse is if you are someone that has constipation and you are straining on the toilet, or you're someone that weight lifts and you do a ton of holding your breath while you exert. Those are things that are pretty common. And as we mature in age, the estrogen or even the testosterone in our body decreases, and sometimes the integrity or the tone in our muscles are not as strong as when we were younger, and that can make the prolapse more prominent. The other thing that we want to consider is that if you've had kids, whether or not you've had a vaginal birth or you've had a C-section, you have had some extra pressure in that pelvic organ. And so what happens is that sometimes it puts you at a place where you're more likely to have a pelvic organ prolapse. And it's often something that a gynecologist will screen for. And so if you have one, then it's something that we can help you with. So what will my physical therapist do? So I think I ask my patients about 90% of the time, did your doctor tell you what to expect when you came in here? And they come in the room and they're very confused and very perplexed and very anxious about what to expect. So this lecture is for you if you have no idea what we're doing and why we're doing what we're doing. So the first thing that we're going to do is listen. We're going to listen to your story. Their story makes a difference in how we treat you and what we're going to do after that. So you might have a story where you have incontinence and you have pelvic pain and you also have like back pain. So those are things that play a part in how we might go about our treatment with you. It's catered to you. It's not a cookie cutter, everyone gets the same kind of treatment. The other thing that you want to keep in mind is that we have patients go into a private room and it's one-on-one treatment. So there aren't a lot of people looking at you. You're not in an open gym when you're having these discussions with us. And we're discussing a lot about your bowel and bladder habits and what you do and what you drink and what you might intake. And then we help you go from there. So what we might do for an evaluation is we assess your movement, and we also might assess your strength and your flexibility. But ultimately what we end up doing at the very end is, yes, we will teach you how to do a Kegel, but what we will also do is educate you on things that you might need to do at home throughout your time that you're not with us, that will help improve the way that you move, or improve the way that you have less pain, or improve the way that you're having less leakage. So just an outline of my evaluation, or an evaluation that you might have from one of our therapists. So we will ask you about your fluid and diet intake. Why this is important is that we're talking about bowel and bladder. So a big portion of, if you have incontinence, or even if you have a pelvic organ prolapse, we need to know what's going on, what you're intaking that's making a difference with how your body is responding. So water intake is huge, huge. We ask patients to drink about 64 ounces of water. So that might be an 8-ounce glass. We asking you to drink 8 of those. Now a typical glass might be 12 to 16 ounces, and that's something that we want you to do. Now, if you went to Costco and you bought one of those bottles that are typically 16 ounces, you want to drink about 4 of those throughout the day. Now, what I want you to do is not chug everything in the morning and then decide that that was okay. No, I want you to drink it throughout your whole day, because that will make a difference on how your body's responding to the water intake. If you just chug everything in the morning, then you will definitely pee on your pants on the way to the bathroom, and that's not something we want you to do. Fiber intake. So we'll go into a little bit more depth about this, but the fiber that you're intaking throughout your day can play a part on whether or not you have constipation, or if you're having fecal leakage or diarrhea. So what it is important is that we have fiber in every meal of the day, so that we're bulking up our bowel movements. And so we'll also talk to you about bladder and bowel irritants. There are various things that irritate our bladder. And so there's various things that irritate our bowel movements, and our rectum doesn't like that either. And so you might find that you're having leakage on the way to the bathroom, not because you're having weakness or tightness, that it's because of everything that you're intaking. And so what we'll also discuss is urine and fecal output. So we'll ask you often how many times you go to the bathroom throughout the day. We'll ask you how many times you go into the bathroom at night as well. We'll ask you the same thing about bowel movements. So what I typically ask, what I expect from patients to say is that they're going infrequently, or they're going too frequently. For bowel movements, we expect that a patient is having 1 bowel movement a day. Occasionally you'll have 2 or 3 a day, depending on what you've eaten. But if you're having bowel movements less than 1 a day, then you're on that spectrum that's more constipated. And that's a concern, because that can play a part in all these different things. Because if you're constipated, it can play a part on your stress incontinence. If you're constipated, it can play a part on making the prolapses worse if you have those. And then we'll ask you leakage. And that's important, because if you have leakage in the morning, that lets me know that there's something going on in the morning. But if you have no leakage throughout the rest of the day, that plays a part. If you have leakage with coughing, sneezing, laughing, then that tells me that you have leakage with stress. But if you only have leakage on the way to the bathroom, then that tells me that there's a high chance that it's mostly urgency. It can be stress related, but it can be mostly urgency. Time of day. So some of our patients will have leakage at night, and some of our patients will have leakage, or they'll get up to the bathroom more frequently at night. So if you are in that realm, then what we want to consider is, do you have any swelling in your legs? If you have swelling in your legs, that will make your frequency to the bathroom more prominent, because the fluid in your legs goes back into your body and it pulls back into your bladder. And so dealing with something like that, we'll address that when we do an evaluation. If you're someone that takes your medication at night, then we'll have to discuss, okay, well, maybe you should drink more water throughout the day and then limit the amount of water that you intake prior to bedtime. And then we'll go into more of our assessment. And so physical therapy is the movement specialist. We will address your posture, your movement. We might assess the way that you walk. We might assess the way that you get in and out of bed. We might assess the way that you get out of a chair, because those are the reasons that you might be having leakage. We might also address your leg strength and your flexibility, because that might play a part in how well you're moving, or if you're having pain with those various movements. The other thing, the big thing, is the pelvic floor muscle strength. We will assess your Kegels, or how well you can perform a Kegel. And why this is important is because if you are having a hard time holding back urine, holding back your feces, or holding back gas, this will tell us a little bit more about the story. So I want to go a little bit more in depth with bladder irritants. If you have stress incontinence, this might be a reason why you're rushing to the bathroom, or this could be a reason why when you cough, you might have more leakage. So caffeinated beverages are a bladder irritant. So that takes out coffee and tea. It might even be like your Diet Coke might be in there. Chocolate and soda. So now when I took this course about maybe 6 years ago for pelvic floor therapy, I went up to the instructor and I asked them, I said, I don't drink soda, I drink sparkling water. But the truth of the matter is it's carbonation. So if you're someone that drinks a Diet Coke, if you're someone that drinks, you drink a latte that has artificial sweeteners, you're going to find that you're rushing to the bathroom probably a little bit more often than most people, because Diet Coke is caffeine. It is also carbonation, and it's also an artificial sweetener. If you're someone that drinks a latte, it has tea, it has dairy, and it also has sugar, which also makes the bladder very angry. Now, I've described bladder irritants. Now you're like, okay, well, you've given me this whole list of these bladder irritants. Why does this pertain to me, or how does this affect me? Now, if you intake a little bit of these bladder irritants, you might find that you have a strong urge to go to the bathroom, and then you sit on the toilet and you're done, and you might be done in 3 seconds after voiding. But that tells me is that you drank a lot of bladder irritants and that your bladder didn't like that. You should be sitting on the toilet and voiding for 8 seconds or longer, but the bladder had that sense of strong urge because it didn't like any of those things in them. So what we want to do is drink more water. So I don't tell patients to get rid of these bladder irritants. What I tell them to do is intersperse it with water. So if you're someone that's like, well, I need 2 cups of coffee in the morning, I just need it. So I would say, drink your cup of coffee, drink some water, drink a cup of coffee, and then try to dilute the amount of bladder irritants. Your bladder doesn't like acidity. So like if you look down further into the bladder irritants list, there's citric foods, there's spicy foods, there's artificial sweeteners, tomato-based products, and concentrated urine. Now, the reason I put concentrated urine in here is because a lot of times we find that patients will say, well, I just limit the amount of water that I drink because, well, I don't want to go to the bathroom. Now, that's not the best solution to the problem. Because if you decided to drink nothing today, you drank absolutely nothing, your body will still filter from your kidneys into your bladder urine. Why it will do that? Because it's still pulling it's still pulling byproducts from your cells throughout your body, and it needs to pool into your bladder. But the reason water is so important is it dilutes the concentration of your urine. And so that's what allows you to hold a bladder more full. So if you feel a strong urge and you find that you're not voiding very long on the toilet, it could be that you're drinking too few ounces of water, but you're intaking more bladder irritants, or you're just not drinking enough water. But when you drink more water, it expands the amount of water or urine that you can contain in your bladder. So the first urge is usually your bladder telling you, okay, I'm stretching. The second urge is really when your bladder is full. But if you're intaking a ton of these irritants, you're going to find that if you don't go to the bathroom right away, you're going to have some leakage. Now, why does it matter if I'm constipated? Like Sonia, I'm not really having an issue with, prolapse. I'm not really having an issue with fecal leakage. I have some constipation and I have some urinary leakage. Like we talked about, constipation can play a part in how you perform or how you have leakage. And so the constipation means that your bowel movements go through your stomach and then they go through your intestine and they end up in your rectum. What happens is that if you're constipated, it puts more weight onto your bladder. So if this is my pelvis, this is my bladder, it's putting more pressure on here. So if you cough, sneeze, and laugh, and you are constipated, and you're like, Sonia, I don't drink bladder irritants, I drink plenty of water, but I'm constipated, you can guarantee that you're having some stress incontinence because of your constipation. Also, constipation, if you are constipated, there are things that we can discuss with you on how to improve that. Sometimes patients will have what we call a dyssynergy. What that means is that their muscles, when you're supposed to be relaxing on the toilet, they kind of tighten up. But we teach you how to relax your pelvic floor muscles, and we might give you some stretches to help you with that. We also will discuss a little bit about your water intake and various things that you're intaking, such as fiber, and maybe you're intaking more processed foods or unhealthy foods that are more sugary. So this is a Bristol stool chart. Now this is kind of gross because I know that we're talking about incontinence, but we're also talking about fecal incontinence. Now, if you look, there's a pipe and it has different variations of what might stool look like. Now, type number 3 and type number 4 are the ones that we are hoping that patients have. But if you have constipation, you're going to have more of the type 1 and type 2. If you're someone that has more leakage, you're probably going to have more of the type 5, 6, or 7. Now, why I have this picture up here is because based on what you come in and tell me, if you're constipated, I'm going to advise different kind of fiber. If you're having some leakage, it will tell me that, okay, I need to tell you about this kind of fiber. So here are soluble and insoluble fiber lists. And so if you're someone that has fecal leakage, if you have fecal smearing, or if you have leakage on the way to the bathroom, or stress incontinence, you're going to find that there are soluble fiber. And so on the first column, we'll see that that is going to help you with the leakage. So oatmeal, lentils, apples, oranges, nuts, all of those things will help you improve your leakage. So I don't suggest that you decide to take everything all at once. I suggest that you take, 1 or 2 items and add them to each meal of your day. And that should help improve your leakage so that it bulks up your bowel movement. Now, if you have if you have constipation, you're going to want to intake more insoluble, which means that it's going to give you more of that laxative benefit. So sometimes patients have harder stool and they don't have enough water or fiber, the right kind of fiber that's going to benefit. So eating things like barley, couscous, brown rice, zucchini, all of those things are going to benefit you. Kegels. The main reason most people came in here today are to figure out what Kegels are, or to tell me, Sonia, well, I've tried your Kegels and they don't work. Most of my patients that come into physical therapy will say, well, I've tried Kegels and I've been doing them since my kid was born, and that was 50 years ago, and they don't seem to be helping me. Well, the truth of the matter is most of my patients, about 90% of my patients, will come in and they'll say, Sonia, I've been doing Kegels and I'm squeezing and tightening up and I don't feel like they're helping. Well, that's the problem. Kegels are not meant to just tighten up your pelvic floor muscles. You're meant to feel a squeeze and a lift. So if we're thinking about the pelvic floor muscles, there are vagina for females, rectum for both males and females. We might ask a patient to squeeze like you're holding back gas. And you might say to me, well, I've been doing that for a long time. But the truth is that when you're sitting down, if you feel like you're doing a squeeze, that's good. That's the first part. But the second part really is a lift. So you should feel like there's a squeeze and that the muscles are moving up towards the head. Now, the reason I have this picture here is not because this is the pearl of our existence here with pelvic floor therapy, but it is because it's a marble. So often a visual that patients might need is that there is a marble at the insertion of your vagina and that you're squeezing on the marble and then you're lifting it up towards your head. Two important ways that I might communicate how to do a Kegel with the patient are squeeze like you're holding back gas. Another one for women tend to be, if you have ever worn tampons, is as if you insert a tampon in your vagina and that you're pulling on the string, and so you're playing tug of war. So you're squeezing and lifting up towards your head as someone is pulling. Why this is important is that the pelvic floor muscles are meant to support. They're also meant to, like we talked about at the beginning, they have sphincteric control. You can dictate when you need to go to the bathroom because you will hold it and then make it to the bathroom. Once upon a time when you were a toddler and you were learning how to be potty trained, you had to learn that your mind has control over your body. Oftentimes what we find is that patients have allowed their bladder to have more control over their mind than you've been needing to do. So what we want to make sure that you're doing is also the squeeze and the lift. And if you are having a hard time with figuring that out right now, then it might be a good idea to come in to see physical therapy. So exhaling while you initiating the Kegel. So a lot of my patients, what they'll do is they'll contract their pelvic floor muscles and they'll hold their breath. And that's like the worst thing that you can do, because I just said to you, because the prolapse is if you hold your breath with exertion, and I know that a Kegel doesn't seem like it's exerting a ton, but what it's doing is that it is increasing your intra-abdominal pressure. So intra-abdominal pressure is anything from below my diaphragm and then to my pelvic floor muscles. So if you can see in the picture here, there is a diaphragm, which is that dark maroon, and the pelvic floor muscles are down below. And so if you hold your breath, you create intra-abdominal pressure and you don't allow room for your pelvic floor muscles to contract and then move up towards your head. If you exhale, what happens is that your diaphragm moves up and it expels the carbon dioxide from your body, and then it allows for the pelvic floor muscles to come up. So how do I treat my incontinence? What will physical therapy do for me? So like we did throughout this whole lecture, is that we've discussed a little bit about educating. For stress incontinence, we'll talk to you about your bladder irritants. We'll talk to you about the strengthening that you might need to do in order to reduce the leakage. For stress incontinence, we do what's called a NAC. So it's something that's a reflex that we have, but sometimes as we mature, the estrogen in our body or the testosterone in our body decreases, and then we have less control. And so we have to work a little bit harder on improving that. So what that means is that the NAC is contracting your pelvic floor muscles before you cough, sneeze, laugh, jump, move. Now you're like, well, that sounds crazy to me. Why would I do that? How could I do that? But believe me or not, like, you can improve that as you get strong with your pelvic floor muscles. With stress incontinence, you might also have tightness. And so we'll address that too when you come in for your evaluation. For urgency, we often will do a we'll do strength test, and we'll also check to see if you have flexibility issues. But a number one thing with urgency is that sometimes it's a habit. So if you, like we talked about, there are triggers for some people. It could be the water's running in the kitchen sink. It could be that you know you're going to pass that bathroom on their way to work. It could be that you drive by that gas station. That's the bathroom that you use when you're on your way to picking up your kids. It could be that you're driving into your garage and the garage door is closing. All those things are triggers. So you're like, well, that's silly. I don't think they're triggers. I really need to go to the bathroom. But I want you to take a step back. There's a reason why you had urgency. It's because you've had more than one accident. And so now you've trained yourself to go when you don't really need to go. And you're like, well, I do need to go. Well, you've created a system or a mindset that has told you need to go. So what I might tell my patients is that they might be sitting and they stand up and then they like, oh, I feel like I need to go bathroom real quick, and they start running, and that running doesn't give you a sense of control. So then I ask patients to sit down, contract your pelvic floor muscles, take some deep breaths. I want you to think about something else, count backwards from 100. I want you to do all those things to help you gain control before you stand up and go to the bathroom. And then mixed incontinence is a combination of the stress and the urgency. The overflow or incontinence is more for our patients that are, sometimes the patients that have BPH. So if you have an enlarged prostate, you might notice that you have overflow incontinence. And what we'll teach you to do is to go to the bathroom within a system so that you're voiding before you have the leakage. Urgency and frequency. So sometimes for stress incontinence, we'll give this to patients, but mostly for urgency and frequency. We will give you what's called a voiding log. A voiding log means that I will give you a sheet of paper, and it might have a whole week on there. And I want you to describe to me when you had leakage and when you're voiding. Why this is important is that we can sometimes, this is helpful for you because it gives you something to write down and then have accurate record of when you're having leakage or when you're voiding. If you're someone that's frequent going to the bathroom, then this will be good feedback for you. You'll look at it and you'll be like, oh, I'm going twice in an hour. And you're like, well, she's asked me to spread it out for 2 hours so that I can have more time for my social life. You might also find that we ask you to do a food or liquid diary. What that means is that sometimes if you're intaking various things that are only done in the morning or in the night, then we'll have a better idea of telling you, okay, step back from this, don't do this. And then we'll help you navigate there. I have a prolapse. What can I do now? So Kegels are the big thing that I want to address with you. Like we talked about the grading. If you have a grade 1, 2, or 3, that's oftentimes where we can help you. Your doctor might prescribe a pessary, and that might be something that is important for you to get in order to obtain your goals. But here are the big educational things that I tell my patients that have prolapses. You can make your prolapse worse, but in order to make it better or to prevent or just stay that status quo, you need to avoid being constipated. So we talked about the water and the fiber intake. We also talked about avoiding straining on the toilet. You want to avoid holding your breath with exertion, and then limit coughing. You're like, well, Sonia, I've got COPD, I have asthma, I have allergies. Now I'm telling you to limit your coughing. I'm not saying that it's sometimes not possible to limit or avoid coughing completely, but that can sometimes play a part in your prolapse. And then perform Kegels with normal breathing. So I'll tell patients to initiate the Kegel with an exhale so that it gives you the optimal contraction of the pelvic floor. But I also want you to contract your pelvic floor muscles while you're still breathing. So we often might tell patients to do 2-second holds or 3-second holds, or we might tell patients to do 8-second holds or 10-second holds. But when you're doing a 10-second hold, I don't expect you to exhale for 10 seconds. I expect you to inhale, exhale, inhale, and then exhale, and then contract on your pelvic floor muscles, but then resume to your normal breathing. So now you're interested. How do I start? First thing you'll do is contact your doctor. So you might call your doctor. If they're an Eisenhower doctor, you can talk to them in my chart and say, I want to start physical therapy for my pelvic health. And then you obtain the PT prescription and then make an appointment. So our department will not schedule you unless you have a PT prescription from your doctor. But if you have all those things and you just want to bring them in, or if you want to fax them, or your doctor is going to fax them because you don't have an Eisenhower doctor, this is how you can do that. So you can send this to your physician and say, I want pelvic health and I want it to be sent to Dolores Hope. We have multiple offices here at Eisenhower that treat physical therapy, but Dolores Hope in Rancho Mirage is the only clinic that does pelvic health therapy. Now, if you have a question or concern, you can always call us at the phone number below, and then our fax number, if you need it, is down there as well. So that's it for today as far as the lecture is concerned. So thank you for your time.